Yes, mute. A very good evening to one and all. I am Arpita, the moderator for today's session from the IGCP group. The topic that we are going to cover today is use of vasopressors and inotropes in septic shock. And yes, to address the topic, we have with us someone very eminent, none other than Dr. Deeptimala Agarwal ma'am. It's an honor for me to welcome ma'am to our platform and to introduce her to everyone. Ma'am is a director of Oxim Enterprises, Agra, Chief Critical Care Services at Shantived Institute of Medical Sciences, Agra, UP. So, ma'am, with this a very brief introduction of yours, I would now request you to please start with your presentation for today. Over to you, ma'am.
Thank you so much, Arpita, for your kind words and introduction. I am thankful to IJCP and MedTalks for having me here. I'll be speaking on use of inotropes and vasopressors in septic shock. What is septic shock? Septic shock involves persistent hypotension, defined as the need for vasopressors to maintain mean arterial pressure above 65 millimeters of mercury and a serum lactate level of more than 2 millimole per liter, despite adequate volume resuscitation. Initially, arteries and arterioles dilate, which decreases the peripheral arterial resistance, and cardiac output typically increases. This stage has been referred to as warm shock. Later, cardiac output may decrease, blood pressure falls, and this is the typical feature of hypoperfusion. Even in the stage of increased cardiac output, vasoactive mediators cause blood flow to bypass capillary exchange vessels, which is the distributive effect. Poor capillary flow results from this shunting along with capillary obstruction by microthrombi, which decreases the delivery of oxygen and impairs removal of carbon dioxide and waste products. Decreased perfusion causes dysfunction and sometimes failure of more than one organ, including the kidneys, lungs, liver, brain, and heart. Septic shock and severe sepsis is a very common entity in the patients admitted to intensive care unit. I have experience of more than 2 decades in ICU. Almost 50% of the patients admitted to any intensive care unit are in severe sepsis. So the early identification is the most important, and once identified, timely management. So when a patient in septic shock comes to you in ICU, this all comes to your mind. It looks complicated, but once you are working in an intensive care unit, over a period of time, you understand how to identify what to use where. So in this slide, you can see the confused young JR who is thinking of which inotrope to give, which vasopressor to give. And all these inotropes and vasopressors, they act on which receptors, what are their actions. So I will try to make it simple and I will try that you understand. So depending on the background of the attendees who have joined, if you are in ICU, you will find the topic very simple. And if you have not worked in ICU, then also few of the slides will take you back to your pharmacology days. So very basic question, what is an inotrope? Drugs that affect the strength of contraction of heart muscle, the myocardial contractility, is an inotrope. So this will increase the strength of muscular contraction. Term inotrope generally is used to describe a positive effect. The choice of agent depends largely on specific pharmacological effects of individual agents with respect to the condition. One of the most important factors affecting inotropic state is the level of calcium in the cytoplasm of the muscle cell. Positive inotropes usually increase this level, while negative inotropes decrease it. Now, what are vasopressors? Vasopressors increase vasoconstriction, which leads to increased systemic vascular resistance. An increase in the SVR leads to increase in the mean arterial pressure, which increases the perfusion to organs. So this is our aim in a patient of septic shock. At the same time, the inotrope, they increase the cardiac contractility, which improves the cardiac output. Again, it aids in maintaining the mean arterial pressure and perfusion to the body. For those who are new, for them, if they don't understand what is mean arterial pressure, I will just tell you. Mean arterial pressure is, all of you know there is systolic and diastolic blood pressure. So mean arterial pressure is diastolic blood pressure plus 1/3 of the pulse pressure. And pulse pressure is systolic blood pressure minus diastolic pulse pressure. So for any critically ill patient and the patient in septic shock, we have to maintain a mean arterial pressure above 65 millimeters of mercury. So that maintains the perfusion of the body and urine keeps pouring. So this slide shows you the receptor selectivity of adrenergic agonists. So these are the drugs we have: epinephrine, ephedrine, norepinephrine, dopamine, dobutamine, and dopexamine. And they have actions on alpha-1, alpha-2 receptors, beta-1, beta-2, and dopaminergic receptors. Now, this depicts the effect of adrenergic agonists on organ systems. Their effect on the heart rate, effect of each drug on the mean arterial pressure, on the cardiac output, peripheral vascular resistance, bronchodilation, and renal blood flow. So I'll tell you about norepinephrine. It will reduce the heart rate, increase the mean arterial pressure, will try to maintain the cardiac output, will increase the peripheral vascular resistance, no effect on bronchioles, and it will reduce the renal blood flow. Dopamine will increase the heart rate, increase the mean arterial pressure, increase cardiac output, increase peripheral vascular resistance, and it will increase the renal blood flow. Dobutamine will increase the heart rate, mean arterial pressure, and cardiac output, even renal blood flow, but it will decrease the peripheral vascular resistance. Now, what is dopamine? Dopamine is an endogenous, non-selective, direct and indirect adrenergic and dopaminergic agonist. Clinical effects vary markedly with the dose. So the action of dopamine is dose dependent. Low dose, moderate dose, and higher dose. In the low doses of 0.5 to 3 microgram per kg per minute, it activates the dopaminergic receptors. Vasodilation of renal vasculature and promotes diuresis and natriuresis. Use of this renal dose does not impart any beneficial effect on renal function. In the moderate dose of 3 to 10 microgram, it has beta-1 stimulation, which increases the myocardial active contractility, heart rate, systolic blood pressure, and cardiac output. So the myocardial oxygen demand increases typically. And in the high dose, it has alpha-1 effect, becomes more prominent, which has effect on, which increases the peripheral vascular resistance and reduces the renal blood flow. Indirect effect of dopamine are due to the release of norepinephrine from postsynaptic sympathetic nerve ganglion. So as I told you, the dopamine has dose-dependent effect. Less than 3 microgram, between 3 to 10 microgram and above 10 microgram. So depending on the clinical situation, we have to adjust the doses. We are using it for which purpose, that has to be clear in our mind while ordering the dose of dopamine. Now we talk of dobutamine. This is a racemic mixture of two isomers with affinity for both beta-1 and beta-2 receptors and selectively higher action on beta-1 receptor. Increases the cardiac output as a result of increased myocardial contractility, reduces peripheral vascular resistance, and it prevents the much of increase in arterial blood pressure, reduces the left ventricular filling pressure, whereas it increases the coronary blood flow. Dopexamine is a structural analog of dopamine. It is good for theoretical purpose. In clinical practice, we have never used it, and I don't think it is available in the market. Epinephrine, adrenaline is very, very important. I'm sure all of you must have heard about adrenaline. This is the endogenous catecholamine synthesized in the adrenal medulla. Direct stimulation of beta-1 receptors of the myocardium cause increase in blood pressure, cardiac output, and myocardial oxygen demand by increasing the contractility and heart rate. Alpha-1 stimulation will reduce the splenic blood flow and renal blood flow, but will increase the coronary perfusion pressure by increasing the aortic diastolic pressure. Systolic blood pressure rises, although beta-2 mediated vasodilatation in skeletal muscle may reduce the diastolic pressure. Beta-2 stimulation relaxes the bronchial smooth muscles. So here you can see the effect of epinephrine in low dose, where the beta-1 action on beta-1 receptors is predominant. And in the high dose, action is on the alpha-1 receptors. So now we talked about epinephrine, adrenaline. Now we are talking about norepinephrine, noradrenaline. This is the most important drug in a case of septic shock. So remember noradrenaline. This has direct alpha-1 stimulation with little beta-2 activity, which induces intense vasoconstriction of arterial and venous vessels. Increase in myocardial contractility from beta-1 effects, along with peripheral vasoconstriction, which contributes to increase in arterial blood pressure. Increase in systolic and diastolic both, but increases the afterload and reflects bradycardia and prevent any increase in cardiac output. There is a reduction in renal and splenic blood flow and increase in myocardial oxygen requirement, which limit the outcome benefits of norepinephrine in management of refractory shock. So if the shock is refractory and not responding to alone norepinephrine, then there is time to add another molecule in treatment. Norepinephrine has been used with an alpha blocker, example phentolamine, in an attempt to take advantage of its beta activity without the profound vasoconstriction caused by alpha stimulation. Extravasation of norepinephrine at the site of IV administration can cause tissue necrosis. So for any patient in septic shock, when these vasopressors and inotropes have to be administered, a central line is always secured first. So the usual route for insertion of central line is through the internal jugular vein. So the dosing of norepinephrine, infusion rate of 2 to 20 microgram per kg per minute, because it has a short half-life. Each ampule contains 2 milligram of norepinephrine in 4 ml. Now we talk of levosimentan. This is a pyridazole dinitrate derivative calcium channel stabilizer. It increases the sensitivity of the heart to calcium, thus increases the cardiac contractility without a rise in intracellular calcium. This drug is of use in a patient of CHF, congestive heart failure. It has limited or rather no role in a patient of septic shock. So this is how the lifosimendan acts and its cardiovascular functions. Now we talk of milrinone. Milrinone, like embrinone, has positive inotropic and vasodilator effects. So it has minimal effect on the heart rate and myocardial oxygen consumption. It again increases the cardiac output by improving contractility, reduces systemic vascular resistance, peripheral vascular resistance, and reduces the preload due to vasodilatation. So it has a unique beneficial effect on the right ventricular function. Half-life is 1 to 4 hours. It is primarily excreted through the renal route. So this is how milrinone acts in the body. Inoximone and piroximone, again, these are of theoretical interest. We have never used in clinical practice, and as per my knowledge, they are not available in the pharmac market. This is a comparison between the levosimendan, milrinone, and dobutamine. So we'll talk about dobutamine here because that is most frequently used in our ICUs out of these three. So dobutamine is a catecholamine beta adrenergic agent. It will increase the intracellular calcium concentrations, will give mild peripheral vasodilatation, will increase the myocardial oxygen demand. It has arrhythmogenic potential, so ventricular ectopics can be precipitated. So one has to be in ICU. That's the aim of a patient in intensive care unit, that continuous monitoring is required. And the side effects or adverse events are tachycardia and increase in systolic blood pressure on overdosage. So these are what we are talking about. When there's a patient in shock, any patient you receive in shock, first you have to ensure the volume status of the patient. Once the volume is maintained and still the shock persists, then you have to think of which drugs to start. And one drug has action on many receptors, and drugs have direct as well as the reflex actions. So these are the points you have to keep in mind. Now we come to hemodynamics in shock. A patient in shock will have low systemic vascular resistance, so arterial tone is reduced. Initially, the cardiac output will increase, and then the cardiac output will fall, and the blood pressure will fall. That is how these patients land in hypotension. So initially, you have started with fluid resuscitation because there is inadequate systemic vascular resistance. There is vasodilatation. Compensatory elevated cardiac output is there initially. So this patient, till this time, patient is in warm shock. But body is trying to compensate by increasing the cardiac output. But when this cardiac output becomes inadequate and there is vasoconstriction and systemic vascular resistance is increased, you will see that the patient has cold extremities. So this is cold shock. This is a stage further down from the warm shock to the cold shock. So patient in shock with cold extremities is very, very, very critical. So now how do you plan your strategy? We have to be very clear that drugs which act on alpha-1 receptors, they are causing vasoconstriction. Action on beta-1 receptors, there is inotropic and chronotropic action, and action on beta-2, there is vasodilatation. So this is the rationale behind our choice of agents in a patient of septic shock. So the aim is to restore adequate blood pressure. So when you are choosing the right vasopressor agent, the aim is to restore adequate blood pressure, and the inotropic agent to increase the cardiac output. So to determine whether cardiac output is adequate in patients with shock is a thorny problem, but we having echo machines in our intensive care units, echo is of great help in assessing regularly the contractility of the heart, the ejection fraction, as well as the IVC. So it helps us in knowing the volume status as well as the cardiac contractility. So in septic shock, there is reduced perfusion pressure, abnormal shunting of blood flow within the organs, inability to use delivered substrates, and downregulation of adrenergic receptors. So now the decision making is very important. As I have already told you, first you have to maintain the volume status, continuous monitoring, and selection of a vasopressor and inotrope to restore the effective tissue perfusion and to normalize the cellular metabolism. So in this slide, you can see the various vasopressors and inotropic agents. So you can see in the circle, norepinephrine, phenylephrine, and vasopressin are being included. So these are helpful to cause vasoconstriction. And on the left side, where there's written direct inotropic effect, here again you see for the vasoconstriction, the drugs of choice are phenylephrine and vasopressin. So norepinephrine, it improves the systolic blood pressure, does not substantially worsen end-organ ischemia in most studies of crystalloid resuscitated septic shock patients. Equivalent efficacy in increasing mean arterial pressure, oxygen consumption, and oxygen delivery compared with other catecholamine pressors. Gastric pH has been observed to increase. Epinephrine is added to and potentially substituted for norepinephrine when an additional agent is needed to maintain adequate mean arterial pressure. Dopamine is an alternative agent to norepinephrine only in highly selected patients. Patients who are at low risk of tachyarrhythmias and absolute or relative bradycardia, because dopamine will increase the heart rate, so it can precipitate arrhythmias. So this will be a drug of choice for the patients who are in relative bradycardia. This is one point which needs to be remembered. Not recommended in treatment of shock except, norepinephrine is associated with serious arrhythmias. Cardiac output is known to be high and blood pressure persistently low. As salvage treatment, when combined, inotrope and vasopressor drugs and low-dose vasopressin have failed to achieve mean arterial pressure target. Vasopressins can be added to norepinephrine with the intent of either raising mean arterial pressure or decreasing the norepinephrine dose. Low-dose vasopressin is not recommended as the single initial vasopressor, never. So in septic shock patient, the first choice of agent is noradrenaline, that is norepinephrine. And vasopressin is the second agent, which is added to raise the mean arterial pressure and at the same time When you add the vasopressin, you will be able to reduce the dose of norepinephrine because single agent norepinephrine, there is a limit to which you can increase the dose. So this is the vasopressin and septic shock trial, very famous trial by the name VAST, VASST. In this, 778 patients with septic shock randomly assigned to either low-dose vasopressin and norepinephrine were taken. 28-day and 90-day mortality rates, there was similar incidence of serious adverse events. So you can see the days since initiation of study drug and probability of survival. And vasopressin and norepinephrine, they are almost similar incidence of adverse events and action. So the message you take bedside to your hospital, to your clinics, is that norepinephrine remains the most commonly used vasopressor and is recommended as the first-line agent. Vasopressin is recommended as a second-line vasopressor, more effective in less severe shock, where adding vasopressin to norepinephrine might help reach the initial mean arterial pressure target faster. Comparing terlipressin to norepinephrine showed no difference in mortality, but terlipressin had more adverse events. Epinephrine is another second-line vasopressor. Adding epinephrine to norepinephrine, aiming to target mean arterial pressure and again to reduce the requirement of norepinephrine. So, two vasopressor strategies, norepinephrine plus dobutamine versus epinephrine in patients with septic shock has reported no difference in both efficacy and safety. So, for the patient of dopamine was used in the past as the first-line vasopressor in septic shock. However, observational studies showed an increased risk of tachyarrhythmias, thus mortality. Now, is there a maximum tolerable dose of norepinephrine? The question of what would be maximum tolerable dose of norepinephrine for achieving the mean arterial pressure target is still not elucidated. It's not still clear. Norepinephrine at high doses usually, but not consensusly defined as more than 1 microgram per kg per minute, is sometimes used as a rescue therapy in severe hypotensive patients. Good consensus among experts to start a second vasopressor in cases of refractory hypotension. Early noradrenaline administration is recommended in order to achieve the initial mean arterial pressure goal of 65 millimeters mercury faster and decrease the risk of fluid overload. So the optimal MAP target should be individualized as it depends on several factors such as history of chronic hypertension and the values of CVP, central venous pressure, and IAP. So the message for all the listeners is there's role of norepinephrine. Noradrenaline is the first drug of choice, and second drug of choice is C-pressin, vasopressin in a case of septic shock. Thank you. Now we are open for questions.
Yeah, thank you, ma'am. Thank you so much for such an insightful presentation, I would say. So with your permission, shall we go ahead with the questions
Sure.
now?
Sure.
Right, ma'am. Let me check what are the questions that have come. Ma'am, the question is, under what clinical scenarios would you recommend a combination of vasopressor and inotropes in septic shock, and how do you monitor for adverse effects?
Just repeat the question.
The question is, under what clinical scenarios would you recommend a combination of vasopressors and inotropes in septic shock, and how do you monitor for adverse effects?
Okay. In any septic shock, Initially, we will begin with, as I told you, first vasopressor choice is norepinephrine, and then we will add vasopressin, cipressin. Still, if the patient remains in hypotension and there is relative bradycardia, that is the time you can add the inotrope, that is dopamine. That is the time you add after having two vasopressors, still the hypotension persists and there is bradycardia. To monitor the adverse effects, there needs to be a continuous monitoring of the ECG, and you have to be on the watch out for any arrhythmias which need to be attended immediately.
Right, ma'am. The next question is, how critical is the timing of vasopressor initiation in septic shock, and what strategies do you follow for titrating doses to achieve the optimal outcomes?
Yes. It is usage of septic shock, usage of vasopressors in septic shock is very, very important, and it has to be initiated as early as possible. You receive a patient in shock in your emergency. Any patient of shock, initially, we have to give the IV fluid and we have to do some resuscitation. But clinically, if you see signs that the patient is not in hypovolemia, which can be assessed by the radial pulse, if the pulse volume is low, then it is hypovolemic shock. But if the pulse volume is good and patient is in shock, and it is not a clear-cut case of MI, it's not cardiogenic shock, then clinically you can you can make up your mind that this is a septic shock. So initial fluid rush, and immediately you start with the vasopressor if the patient is in shock. What next? There was some other second part of the question.
Just a minute, ma'am. And what strategies do you follow for titrating doses to achieve optimal outcomes?
Yeah. Initially, we begin with not minimum, moderate doses, and our target endpoints are to maintain a systolic blood pressure. As I said, mean arterial blood pressure of 65 millimeters of mercury. So if your monitor does not show mean arterial pressure of 65, you have the systolic blood pressure. Systolic blood pressure of above 90 millimeters ensures perfusion in the body. So end targets are mean arterial pressure above 65. If you do not have mean arterial pressure, you do not know how to calculate, or it depends on the center where you are. Maintain a systolic blood pressure of above 90. Maintain urine output above, depending on the weight of the patient. Urine output is 1 to 2 ml per kg per hour. So you have to maintain a urine output between 50 to 80 ml per hour. So hourly urine output is very important. So you have to maintain the blood pressure, perfusion, and the heart rate. Patient in septic shock, usually they will have tachycardia. So once the resuscitation is done and vasopressors have been added, pulse rate will settle, blood pressure will go up, and the urine will start pouring. So very simple and basic ways to ensure that urine starts pouring, and you have to prevent the acute kidney injury by maintaining the blood pressure. So these are the end target points.
Very nice points, ma'am, that you have mentioned. Moving on to the next question. In patient with septic shock and concurrent myocardial dysfunction, what is your approach to the use of inotropes, and how do you balance their benefits and risks?
Yeah. Once you have started the treatment for the patient in septic shock by adding your vasopressors, right? Now it's very important to get a bedside echo done immediately. As I told you, in the echo, you will come to know the cardiac contractility, ejection fraction of the patient. In acute septic shocks, the ejection fractions, they go down to even 20%. We have seen in clinical practice. And once the patient recovers, ejection fraction also improves. So with a patient of such low ejection fraction, fluid balancing is very, very important. So for these patients, we will have a central line, and any patient with two vasopressors, we always put a arterial line also. So after that, when you have pulse to pulse monitoring of blood pressure, then it becomes easier when to add an inotropic agent. For the inotropic agent, as I said, if there is relative bradycardia, then third drug would be dopamine. But in other cases where ejection fraction is low, but systolic blood pressure is at least 80, in such cases, dopamine can be added.
Right, ma'am. Thank you so much for answering the queries. Ma'am, with your permission, can we take the last question for today?
Yeah, sure.
Okay, ma'am. The question is, what are some emerging therapies or novel vasopressors or inotropes that show promise in septic shock management, and what challenge do you foresee in their clinical application?
See, the studies have been, till now, the drugs which have been proved are noradrenaline and vasopressin in septic shock. There are studies being conducted, but none of the molecules which I have mentioned seems more promising than these two at present. Here I would add, not a vasopressor, but there is another molecule which we have been using and I have been using since almost 15 years in any patient of septic shock. The moment patient goes on to vasopressors, we add, there is a molecule not related to vasopressor, but it is ulinastatin. If those who are working in critical care, they must be aware. If you add it along with the two vasopressors, there is very good response by the body. And within 24 hours, you will notice that tapering of the vasopressor agent starts. So there is no novel vasopressor agent in my knowledge, but this ulinastatin molecule, it works wonders.
Right, ma'am. Thank you so much. With that, we come to an end to our session. But ma'am, I would sincerely like to thank you for taking the time to share your valuable insight on this use of vasopressors and inotropes in septic shock. And your expertise and practical guidance have greatly enhanced our understanding of this very critical topic. So thank you so much, ma'am. And thanks to all our audiences for joining in, for putting up their questions. These questions make the sessions more engaging. So thank you all for joining in. Thank you so much, ma'am, once again for your effort, for your time, everything. Thank you so much,
Thank you.
ma'am.
Thank you so much.